Good morning, everyone. As you know, I'm Dr. Nilesh Salgar. It is a real honor for me to be here at the Ritter Forum. The title of my lecture today is Implant Success with Osseodensification and Crestal Sinus Grafting, and it's part of the Ritter Forum here at ADEC. I come to you from the beautiful city of Montreal, and it is my second time here in Dubai. And there's a little bit more to Dubai than just the palm and the frame and the Burj Khalifa. If you've been to Dubai only once, I urge you to really get out of the city, go into the desert, and I promise you that the sunrise from 4,000 feet is quite spectacular. I had the chance to do some motocross, and I promise you that the sharks in Dubai do not bite. Okay, so I had some fun in Dubai. So this is an implant forum, and when we talk about implants, when a patient will Google what an implant is, they're going to find screws with bones and blood. Patients don't really want implants. What patients are really looking for are beautiful, healthy, white teeth. And why are teeth so important? So teeth are truly, truly important in our patients' lives. So what is implant success? When we talk about implants, there are two words that are generally used to describe them. One is success and one is survival. Success means that the implant meets all the criteria of which it's being evaluated with. So it has thick, healthy bone. It has thick, healthy, keratinized tissue. It has a great emergence profile. It has beautiful aesthetics and occlusion. Survival just simply means that the tooth on the implant is simply there in the mouth. It has no meaning other than the fact that it is present. This is a patient that used to have periodontal disease. This is a patient that used to have very poor oral hygiene, used to have bone loss. It took a while for this patient to change his habits and now become a patient who is able to take care and maintain an implant. And that implant is this one right here, the first premolar. So how are you going to improve your implant skills from where you are now to where you want to be tomorrow? You must follow the rules of implant dentistry, and they're well established. Dr. Carl Misch said, the bone sets the tone. So the ideal amount of bone for an implant is to have at least a minimum of 2 millimeters on the buccal surface. Always strive for more. Dr. David Garber printed, the tissue is the issue. The ideal for an implant is to have at least a minimum of 2 millimeters of keratinized tissue on the buccal. Always strive for more. Here we have an implant with 5 millimeters. Dr. Scott Gans, the scan sets the plan. You must always use a CBCT. It is the standard of care for implant placement. This is an implant which is a 5 by 10 millimeter implant where we're going to do a sinus graft. You must always make sure that you use a CBCT to plan your cases properly. Dr. Dennis Tarnow, the buccal plate sets your fate. Here's a patient who 15 years ago had a small abscess on the apex of her tooth. It would have been a simple case of extract and immediate implant placement. 15 years of convincing led to this huge fenestration in the buccal plate. For me, this is not a case where I would place an implant immediately. We're going to graft, we're going to wait, and we're going to place our implant in the future. Dr. Barry Goldenberg, the clue is in the screw. What type of connection do you have between your implant and your abutment? Is it a legitimate or is it a stock abutment? Is it a tie base or is it a CAD/CAM abutment? So what I've done is over the years, I've assimilated all of this information and I've come up with my own phrase, which I'd like to share to you today. When you are looking at the implant site into which you're going to place your implant, if the implant doesn't fit to bone, tissue, and sinus grafts, you must commit. And as Morpheus said to Neo in The Matrix, the rules of implant dentistry are no different than the rules of a computer system. Some rules can be bent, and other rules can be broken. And I'm going to show you this case a little bit later today. So once again, if the implant does not fit to bone, tissue, and sinus grafts, you must commit. And you must always remember to begin with the end in mind. Your final prosthesis, whether it's a single crown, multiple crowns, a denture, or an all-on-X, that is your final prosthesis. That is the end result that you want to achieve. But remember that an implant's only function is to support a tooth or the teeth. And starting with your final prosthesis, that takes you back to your implant site. You must assess that site and see whether it needs a bone graft, a tissue graft, or a sinus graft. Then that leads you to assessing the type of surgery that you're going to be doing, and then that will lead you to the ideal final prosthesis. And when you're looking at your implant site, you're going to be taking a look at whether you're going to need horizontal bone grafting, which is rather straightforward in the trained hands. You're going to look at soft tissue grafting, which again is fairly straightforward in a well-trained hands, and vertical bone grafting, which is a little bit more complicated and requires a little bit more of advanced training. And in this category, I will place sinus grafting. You have to also remember that it's not acceptable to have implant placement in unusable areas prosthetically. And this is especially true in the aesthetic zone. It is tissue management that is the key. Ridge augmentation, bone and soft tissue augmentation, and grafting greatly increase the range of treatment options that are available for proper implant placement and prosthetic choices. This is a case that came into my office like this. She had been going for years with a high smile line and a visible implant. It took 2 connective tissue grafts to bring her to a level where she could actually smile again. You must also strive for prosthetic-driven site development. It is the bone availability in both quantity and quality that will determine the size and placement of your dental implants. You must have prosthetic-driven implant placement. It is the final restoration and the prosthesis that determines the number of implants, their size, and their positions. And for prosthetic long-term success, you must have ideal implant positioning and ideal bone and soft tissue. This will then allow you the proper abutment selection and prosthetic design. And impeccable oral hygiene is the key. The first case was placed by a surgeon that is very well known. The second case, you had a 4-unit bridge that simply fell out, and all you had to do was do a simple case of bone grafting, tissue grafting, and you already had that 4-unit bridge. You had a surgical guide. The implants simply needed to be placed underneath those pontics. And on a post-it note, this is a sketch that I drew of the kind of truly angled abutment that would have been needed to solve this case. So I sent it off to a specialist. I once asked my friends online what would they prefer having in their office, walk in through the door. An implant that is relatively well positioned but had poor bone and poor keratinized tissue, or another implant that had a poor position but relatively good bone or keratinized tissue. And the answer was somewhat split in half. The surgeon said, well, I prefer the first case because it's very straightforward. I'll simply graft bone and tissue. Done. The non-surgeons chose the second option, this one here. And they said, well, I'm not truly comfortable with bone or tissue, so I'll use some sort of angled abutment, and the case will work out fine. So in both cases, this is not what you're going to strive for. And when we're looking at implant position, again, another case that walked to my office a long time ago, you had a 3-unit bridge that was on natural teeth, and all the surgeon had to do was place the implant adjacent to this bridge. But this is what we found on a radiograph. And not only was this done in the patient's lower right, but this was also done in the patient's lower left, as well as the patient's upper left. So once again, these are the cases that you strive not to do, and I beg you, please don't do anything like this in your own practice. So how do we become better clinicians? Let me show you a case. When we look at this case, what do we see? We see that there are gaps between the teeth. We see that there are teeth that are short and wide and don't have a right ratio. We see that there's a gummy smile, and we see that there's a poor occlusion, et cetera, et cetera, et cetera. But if you're only looking at teeth and looking at only a vacant site, then you're not looking at the big picture, okay? Don't be a single tooth dentist. You want to be a dentist that treats the full mouth. So to become better clinicians, you really have to look at the big picture. And the key is to keep educating yourself. Always learn, always come to conferences, always take hands-on courses, always learn from the best. And I'm really happy to say that many of my teachers and my mentors are sitting here in the front row with me, and they've not only gone from being my mentors, they are now my friends. And at one point, many, many years ago, I used to not place implants. They were too difficult and too complicated as to what I felt. Then I placed a few implants, and I placed more. Then I learned, and I learned from the best. And now these are the cases that I do, and now these are the cases that I teach. One of the factors that led to me becoming a better surgeon is the fact that this case here in particular shows that there are many disciplines within the realm of implant dentistry. And one of the factors that helped me truly achieve my goals was osseodensification. And just in this one photo, you can see that you have crestal sinus grafting, you have septum expansion, you have immediate implants placed in sockets, you have ridge splitting and ridge expansion. All of this is achievable with osseodensification. 9 implants were placed in this case, along with Curi plates. So that was the patient's upper right. This is the patient's upper left. Again, sinus grafting, immediate placement, piezo, ridge split, etc., all achievable with osseodensification. So my lecture today is on osseodensification as specifically as it relates to crestal sinus grafting. So what is osseodensification? It is the use of special burrs that are run counterclockwise in reverse to create the osteotomy for the dental implant placement. The expansion of the bone in the osteotomy by these burrs results in increased bone density in the osteotomy site. With this, you can achieve a higher bone-to-implant contact, a higher increase in the insertion torque, and greater primary stability of the implant. How does it work? Well, unlike a traditional burr, these burrs do not excavate bone. They do not remove bone. They simply move bone. The bone tissue is simultaneously compacted and autografted, outwardly expanding directions in the osteotomy. These burrs are rotated at high speed in a reversed, counterclockwise, non-cutting direction with steady external irrigation, and a strong, dense layer of bone tissue is formed along the walls and along the base of the osteotomy. And here you can see in the porcine tibia, a standard drill, the osseodensification bills that are run in forward motion to extract, and osseodensification where they run in reverse. And you can see a thick, dense bone halo around the walls of the osteotomy. And that's how osseodensification works. What can it do for my patient? Today, I'm going to be talking to you about crestal sinus grafting. It makes crestal sinus grafting safe, simple, and predictable. And when we're talking about the maxillary sinus, let's take a look briefly at some anatomy. In the skull, there are some main sinuses, the sphenoid, the ethmoid, and the frontal, but the one that concerns us the most as dentists is the maxillary sinus on the left and the right. And the sinus is pyramidal in shape. So you've got the base of the pyramid, which is going to be the lateral wall of the nasal cavity. You've got the apex of the pyramid, which is going to be in the zygomatic process. You've got the roof of the pyramid, which is the orbital floor, and you've got the floor of the pyramid, which is the alveolar process of the maxilla, and the front and the back of the maxilla. So when you're looking at a patient in an anterior view, that pyramid is facing outward towards the zygoma. When you're looking at a patient in a lateral view, that pyramid is facing, again, in this direction. And when you're looking from the top down, the pyramid is facing in that direction. So what options do you have when you're dealing with an implant that needs to be placed near the maxillary sinus? First option is the traditional lateral window, which is in the past known as standard of care. You can also place short implants to try and avoid the sinus. You can place angled implants to avoid the sinus, which I've actually never placed an angled implant because of osseodensification. I've never needed to, and I'll show you why. Zygomatic or pterygoid implants can be used. I am trained in zygomatic and pterygoid implants. For right now, I will say that I don't feel the need to place them because of osseodensification, and I'll show you the cases why. And you can use the crestal approach to deal with the maxillary sinus. And the challenges of the posterior maxilla are that you usually have periodontal disease in this area. The maxillary molars are trifurcated, which means periodontal disease and bone loss progresses more rapidly in a trifurcated tooth than a bifurcated tooth or single-rooted tooth. You can have post-extraction atrophy, where a tooth has been extracted some years ago and the bone atrophied, sinus pneumatization, as you can see in the photo in the background, poor bone density. The maxilla in the posterior usually is type 4 bone, which is very spongy and almost of a density like styrofoam, and you have high occlusal forces. And these challenges are where you have very low residual bone height, RBH. You have the presence of teeth, which makes a lateral window difficult when you have the roots of adjacent teeth right in your way. The sinus shape, the sinus size, you can have a septum, you can have an artery, and you can have pathology. All of this makes treating the sinus a little bit more difficult. The lateral window does have its advantages. You can have a large edentulous area which you can treat. You can add a large quantity of bone volume, and you can have a tremendous increase in vertical bone height in the 10 millimeter plus range. You can easily visualize the sinus membrane, and you have easier access to your sinus into which you can do your bone graft. But the disadvantages are that it is an advanced procedure. You need highly advanced training in order to perform the lateral window. It's a large flap. It has a thick bony wall in many cases and blood vessels that are in the way. And there's an increased risk of membrane perforation if you're not careful. And the perforations can be quite bad. And the patient usually tends to have more pain and more swelling. The crestal approach has many advantages as well. You have the fact that it is a much simpler procedure. It is a minimal flap. Oftentimes I'll describe it to a patient as almost being a paper cut. You have less chance of membrane perforations if you're well trained. Less bone will escape into the sinus, and you usually have less complications and much less pains. Many times patients will come to me and question why they're not in pain. Do they really need to take their ibuprofen? I'll say, yes, please just take some. It does have some disadvantages as well. You traditionally were told that you needed at least 5 millimeters of bone height. It is traditionally called a blind procedure. You are traditionally told that you would achieve only limited vertical elevation in the range of 3 to 5 millimeters. Your implant could escape into the sinus, so I'll ask you, please don't do that. And you must know the lateral window, which is a prerequisite. I do urge you to learn the lateral window. I'm going to show you that this disadvantage that you need 5 millimeters of bone height slowly has been pushed. The boundaries have been pushed from 5 to 4 to 3, and I'll show you where we can do it where it's less than 1. Limited elevation. Also, this disadvantage has been eliminated. You will get far more than 3 to 5 millimeters of elevation. I can show you where you can get 10, 12, 15, and plus. Blind procedure, you'll see a video where you can see very clearly the sinus membrane. So it is far less of a blind procedure than is usually described as. So here's a case where you've got an edentulous posterior maxilla with a large maxillary sinus. Those two radiopaque rectangles are gutta perca. So anyone who's ever done endo knows that gutta perca is roughly 1 millimeter in diameter. So just a show of hands, who here thinks that this is a great case for lateral? Nobody. Who here thinks that would be a great case that could be done via crestal? And I'll show you that it could be done via crestal. Here's another case where you've got the same type of situation, except there's a complication with a vertical transverse septum, compartmentalizing this sinus into 2 parts. And here's another case where you have a severely pneumatized sinus, which is between adjacent roots. And I'm going to show you these cases a little bit later, showing that these were easily done with the crestal approach with 10 plus millimeters of bone grafting. I'm going to be showing you 2 cases today, one on each extreme end of the spectrum. One This first case is a case where if you're well-trained in osseodensification, any one of us can do very, very easily with the proper training. It is a very standard routine case for osseodensification. The other case I'm going to show you is on the extreme other end of the spectrum, where it should be only done with extreme training after having done multiple 20, 30, 50 crestal approaches before you even attempt such a case. So in this case, this is a tooth number 26, the first molar on the upper left, where I'm going to be placing a 5 by 10 millimeter implant using the osseodensified crestal approach. So once again, CBCT planning is the key. We're placing a 10 millimeter implant. I've only got 6.5 millimeters of remaining bone height, RBH. Always use the CBCT. It is a standard of care for all implant dentistry. Once again, we can see that there is post-extraction atrophy. Luckily, in this case, not too much bone was lost, not too much tissue was lost. It's a very, very simple case of advancing the flap or buccal roll flap or connective tissue. A full thickness flap was raised. I like to make a little purchase point with a round diamond, which allows the osteotomy burrs to stay in their track. Then we have the first drill, which is a 2.0 diameter osseodensification burr, and that burr is taken to within 1 millimeter short of the sinus floor. And that's confirmed by a radiograph. You can see the guide pin is just below the floor of the sinus. The next burr is the 3 millimeter burr, which is then run, as usual, about 800 to 1200, 1500 RPM in counterclockwise. It's run in reverse with a gentle modulating pressure, and the burrs advance in 1 millimeter increments towards the sinus floor, to the sinus floor, and then to breach the sinus floor to a maximum of 3 millimeters past the sinus floor. So now you'll see the 3 beeps is going in reverse, and we're going very, very slowly. We have all the time in the world. There's no rush. We're going to now 3 millimeters, advancing 4 millimeters, backing it up 5, 6 millimeters. And now we're going to be reaching the cortex of the sinus floor. And then very slowly we'll breach the floor of the sinus, and we have now gone into the sinus. So here we have the final osseodensification burr. The final burr for a 5.0 millimeter implant is usually 0.5 millimeters less, so it's a 4.5 millimeter burr. And here we have the crestal sinus window, and you can see the intact Schneiderian sinus membrane. This is the radiograph that is taken immediately after breaching the sinus floor, and you can see this small dome-shaped structure, which is the autogenous bone, which is fully contained under the intact Schneiderian sinus membrane. So you know that you have not perforated the sinus membrane. So once that is confirmed, you'll then fill the osteotomy site with hydrated mineralized cancellous allograft. And then the osseodensification burr is now used in a counterclockwise motion, very slow RPMs, 150 RPMs, counterclockwise with no irrigation. And again, this burr is now used to propel the allograft underneath the sinus membrane in a very gentle manner, and the burr is not advanced any more than 2 or 3 millimeters past the sinus floor. So here we go. The addition of the cancellous hydrated allograft into the osteotomy site. The burr is then placed into the osteotomy. 3 beeps is going in reverse, 150 RPM, no irrigation, very gentle modulating pressure, and you can feel a tactile sense of that intact sinus membrane making that burr bounce against the drill, and that allograft is then going to be propelled underneath that sinus membrane. Roughly each increment of bone that you're going to place in there is equivalent to a 1 millimeter vertical increase in height. So we did this several times, and then once again, a radiograph was taken to confirm our progress. And we see that dome structure again where the allograft is fully contained under the intact membrane. And here we have an increase of roughly 5 millimeters in vertical height. But I'm greedy. I'm not satisfied. I'll add a little bit more. The allograft is placed again into the osteotomy site. Each increment like this is equivalent to roughly 1 millimeter of vertical bone height. And I can feel the sinus membrane pushing back and bouncing against the burr. And here we have the final radiograph. Again, that dome-shaped structure like this, where you've got an increase of about 10 millimeters of vertical height. We're going to place our implant. There it is, ready to be placed. 5, 4, 3, 2, 1, done. That's what implant placement is. And I get applause for that too. So there you go. We have a 5 by 10 millimeter implant placed roughly 1 millimeter subcrestally. As Dr. Raquel mentioned earlier, the only repeatable, predictable, reliable way to measure the strength and stability of your implant is with an ISQ, implant stability quotient. It is where a peg is connected to your implant and a magnetic resonance frequency is bounced off of that peg and leads to a numerical reading. It is the only way to reliably and predictably measure the strength of your implant. But I also use this peg for my own reasons, which is to check the 3D angulation of my implant placement. So here you can see that the implant is well placed in a mesiodistal direction. Here I can see that the implant is angled perfectly in a buccolingual direction. And I can see, looking down from the occlusal view, that the axis screw of my molar crown is going to be in the dead center of the central pit of the central fossa of the grooves of my molar. And the ISQ is 86. Anything over 68 means that it is ready for immediate loading, but I will let this implant sleep for about 3-4 months because of the crestal grafting. Any implant that has a high IQ like this, I have respect for. Any implant whose IQ is at least equal to or greater than my speeding tickets. So cover screw is placed. I did some veneer grafting, some cortical allograft this time, a membrane, and final sutures. And this is what the final radiograph looks like. So we have an increase of bone height of at least 10, 11 millimeters. The next case that I'm going to show you is the complete opposite end of the spectrum, an extreme case where a crestal sinus window was done in less than 1 millimeter of bone height. So here you have an edentulous maxilla with a large hyperpneumatized sinus like this. And look at the thinness of that bone. That bone is thinner than paper. Full thickness flap was raised, and you can see the bone was so thin that already before starting, you had a perforation of the bone and a perforation of the membrane. 2 gutta-percha markers were placed just to confirm the osteotomy sites visually and on a radiograph. And again, gutta-percha, if you've ever done any root canals or endodontic treatment, the thickness of gutta-percha is roughly 1 millimeter. So that sinus floor is 0.2, 0.3 millimeters. So the first burr that I'm going to use in a case like this is a 4.0 diameter osseodensification burr, 1100 RPM counterclockwise with gentle modulating pressure, and it's advanced in 1 millimeter increments past the sinus floor. And again, that floor is less than 1 millimeter, so I don't have to advance it more than 1 or 2 millimeters. So here you go. I'm angling the burr slightly away from that perforation in the sinus membrane. These osseodensification burrs, if well handled, do not tear the sinus membrane. So you're going to see in a few seconds, I'm applying gentle pressure, gentle pressure again, and the floor of the sinus is going to be breached now. And that bounce is the sinus membrane bouncing against the tip of the osseodensification burr. I move from the 4 to the 5 millimeter osseodensification burr, which is the protocol to go from depending on how much RBH you have left, from 3 to 4 to 5, skipping the intermediate burrs. So this 5.0 burr at 1100 RPM counterclockwise is then used to enlarge the circular osteotomy. And again, you can see it breaching the sinus floor. And I've got 2 osteotomies, one on the mesial, one on the distal. So there you go, 2 crestal windows of a diameter 5.0. And you can see the 2 perforations in the sinus membrane, which were already there before the start. The final burr, 5.5, which is the largest in the kit that I have, which are then used again, 1100 RPM counterclockwise. And what I'm just simply doing is I'm advancing it, and I'm just using the hydrodynamic fluid to push that sinus membrane slightly away from the sinus floor. And there you go. 2 osseodensified crestal windows of a diameter 5.5 millimeters. And again, you can see that perforated sinus membrane. And just like the technique of a lateral window, I will use a curette to simply lift that membrane off the sinus floor. Make sure that you always keep the tip of the curette firmly against the bone, and you're lifting that sinus membrane very, very gently off of the sinus floor. Very gentle. Just like that. So there you have it. The Schneiderian membrane is fully lifted from the sinus floor, and you can see the 2 perforations, which I'm going to treat now with a long-lasting cross-linked collagen membrane. I've reduced one end of the sinus collagen membrane so I can slide it in through the osteotomy holes. And there you have that long-lasting collagen membrane is now sealed the 2 perforations of the Schneiderian membrane. So now we're going to fill this osteotomy with hydrated mineralized cortical allograft. And the burr is then going to be used once again, that 5.5 diameter osseodensification burr, 150 RPM counterclockwise. So that allograft is being placed into the osteotomy site, and you'd almost think that this looks like a lateral window if I didn't tell you, if there was a septum and you did 2 windows. Look at the size of the dental mouth mirror compared to the osteotomy sites. That is just a simple standard dental mirror, and it looks huge compared to these osteotomies. 5.5 burr, used 150 RPM counterclockwise, gentle modulating pressure, advanced 1 millimeter increments, and I can still feel that sealed sinus membrane pushing against my burr and creating that bouncing effect that you saw in the video. This is the interim radiograph, where you can see again that dome-shaped structure, fully confirming that all of the allograft is fully contained under an intact Schneiderian sinus membrane. There is no bone escaping through any perforation. So again, I'm greedy, I want a bit more. So I'll fill that osteotomy with, again, allograft, and use the burr once again in a counterclockwise motion to push that membrane higher and to give me more vertical bone height. So I fill one, I fill the other. Sade's playing in the background. 3 beeps, reverse, 150 RPM, 0 irrigation, and I can feel that membrane pushing back against me as the allograft is expanding underneath that sinus membrane. I'll simply seal the osteotomy with more allograft, close it with a membrane, final sutures. And if you're curious to see the final result, I'll show it to you, only because you asked. So here you go. This is the final radiograph with the increase in bone height. This is the dome-shaped structure of a crestal sinus graft where you've got at least 18 millimeters of vertical bone increase in height. We'll confirm that on the CBCT. One of the questions is, Does this bone reach the medial wall? And yes, you can see that it does. So you can see we've got a vertical increase of 18 millimeters through a crestal sinus graft, where the bone that you started off with was less than 0.2, 0.3 millimeters. So the case that I showed you at the very beginning, this large posterior maxilla with the hyperpneumatized sinus, can it be done via crestal? Again, the two Guttapercha markers, roughly the 1.5 millimeters of remaining bone height. Here we go. In that particular case, two windows, diameter 5.5. This is the result that we got, where in the distal, we got 12 millimeters of bone height. On the mesial, we got 15 millimeters of bone height. The other case that I showed you earlier, edentulous posterior maxilla complicated by transverse vertical septum. Can this be done via crestal? Let's take a look. Again, we can see in 3D what that sinus looks like. And you can see easily the compartment of the sinus. The RBH, the bone height that we started off with, was roughly 1.2, 1.9 millimeters on the mesial and on the distal aspects of the osteotomies. Here we have our osteotomies, where you can see I went mesial to the septum, I went distal to the septum, and this is the result that we got. 13 millimeters and 11 millimeters, final bone height. So an increase of roughly 10 and 12. And here's that case that's been in the background, a severely pneumatized sinus that is between adjacent roots. And you can see this is what it looks like. This is how hyperpneumatized this sinus actually is. And there is an artery that is clearly visible in this picture. Not a good case for a lateral window. Crestal sinus window, large diameter, 5.5, and this is the result that we got. An increase of 13 millimeters of vertical bone height in this case. So, osseodensification can be used very easily in the well-trained hands for sinus grafting. It can be used to osseodensify bone, it can be used for ridge expansion, guided surgery, septum expansion, and for ridge splitting. In conclusion, I want to just remind you that implants are not a surgical treatment, they're more of a prosthetic treatment. The only reason that you're going to place that implant is to replace a missing tooth or teeth. Bone and tissue grafting greatly increase the range of treatment options available for prosthetic choices. A CBCT will minimize the complications and injury due to the knowledge gained of the anatomy during the 3D planning. Osseodensification is one powerful and valuable procedure in the armamentarium of the implant surgeon. And it's the clinician's experience, surgical skill, and cautious planning that are crucial to the success of bone grafts and implant placement. Once again, if you're looking at that implant site where you're going to be placing your implants, if the implant does not fit to bone, tissue, and sinus grafts, you must commit. There are some people that in general just seem to attract trouble. I'm one of them. And my encounters with law enforcement have taught me some very valuable lessons in life and also some very valuable lessons on implant dentistry, believe it or not. And I'm going to share that with you today as I close. You can run from the cops. Not that I've ever done that. But you cannot run from your implants. Once you place an implant, that implant is yours for life. So please place your implants perfectly. Thank you. My contact information is there. It's been a pleasure.
Thank you, Nilesh, for a wonderful lecture. Just one question, if you don't mind. When you do 10 millimeters, how much time do you wait before you go in again?
To place the implant?
Yeah.
I will take a CPCT roughly 6 to 8 months. I've told the patient ahead of time, this is a long marathon. It is not a sprint. We have all the time in the world. You have to agree to that first.
Perfect. Thank you.
The bone tissue and sinus grafts, you must commit, and the patient must be committed as well.
Thank you. A token of appreciation and a certificate for the next.